So we have seen during the last few years publications from the CLL12 trial testing preemptive treatment for patients with CLL without meeting the criteria for starting treatment based on IWCLL, but being high-risk patients. These trials were positive but did not improve overall survival, and it was not considered to change the treatment paradigm for patients with CLL. What we have done with the PreVent-ACaLL trial is to use a machine learning algorithm called CLL treatment infection model, identifying by this model the 20% of patients newly diagnosed with CLL who have more than a 70% risk of having a severe infection or needing CLL treatment within 2 years from diagnosis. The reason we did that was that we realized an unmet clinical need in terms of patients diagnosed with CLL who suffered from serious infections before meeting criteria to start treatment for CLL. And we wanted to change the immune dysfunction for these patients. And we are testing that in an ongoing clinical trial, the PreVent-ACaLL trial, where we treat patients with short duration of targeted treatment with Acalabrutinib and Venetoclax, and it's randomized to standard of care, which would be observation. The primary outcome being safety, but also as a secondary outcome, monitoring the infection-free, treatment-free survival for these patients. In parallel, we assess the immune function for myeloid cells and T cell subsets and the combined efficacy of the immune system in whole bloods from these patients. And what we see now is that during the treatment and after end of treatment for these 3 cycles of targeted agents with Acalabrutinib Venetoclax, we see signs of improvement both in terms of T cell functions, in terms of the myeloid compartment, and in terms of the combined efficacy of the immune system tested by true culture assays, where you do a standardized stimulation of the toll-like receptors and measure the cytokine release upon that stimulation. And why is that important? Because we want to change the natural history of immune dysfunction in CLL, and we now have a plenitude of different treatment options, but we also have different criteria that we need to test both in the primary or first line treatment, but also for secondary relapses, to see when would we actually best start treatment to see if we could improve the immune function and in that way target the major cause of death for patients with CLL still being infections.